Okay, if you've come for an infection control lecture, I'm not giving an infection control lecture. I'm going through the criteria for accreditation. I'm whipping through some because they're things that already should be embedded in your normal everyday practice that just need some tweaking. But I've found that the issues that are worrying most people are the aseptic non-touch technique and the antimicrobial stewardship. And everybody's in a panic. I'm getting all these calls, oh my God, how am I going to do it? It's so hard, I don't understand it, etc., etc. So I'll just quickly go through it. The hospital has it at a much higher level that you will require at the agency. My policies are in draft format and should be out soon to help you understand where we're at with it. You do not have to have the high scale level that they are asking for. That is for acute public or acute hospitals themselves rather than at a dental level. But because we get accredited as a hospital, we have to have it at some level. So it's not as bad, we don't have an inbuilt pharmacy department, etc., etc. So we can't do a lot of the things. Now technology and me, let's see. No. So standard 3 is hospital acquired infections. I actually don't know why they came up with that title, but it was something that as the committee, it was the best of all the options that we could have. And it's preventing and controlling hospital acquired infections. Hospital acquired infections are a big issue in every other big healthcare facility. They're not a big issue in dental, but they are a possibility. Criterion 1, there's several different criterion that cover different things. So this is a governance system. You have to make sure everything is in place, that everything is there, that you can have protection against yourself and that you've written down every aspect of management that you need to do. Mainly it's policies and procedures. If you're in a community health centre, your policies and procedures will already be embedded within the community health centre, but you must have dental specific. You must have management of water lines. You must have management of your clinical space and your clinical environment, management of your instruments, how you stock them. You have to make sure that you abide by 4815, or if you're with a hospital, 4815 or 4187 as your standards for sterilisation. So all those things have to be in there. New to most agencies is the fact that they have to have a staff health base. You have to know your staff's immunisations. You have to know who's current, who's not current, and it's something that you do have to have. I know there's a lecturer going around saying, oh, it's a breach of privacy, you can't do it. I rang the department and said, what's changed? No, there's something new going on, I've missed it, what's happening? And they said, no, you must, every healthcare worker in your organisation, you must have a history or notation of their vaccinations. And if they're not vaccinated, or they're unable to be vaccinated, or they haven't seroconverted to, say, hepatitis B, you must be aware of that. If an incident happens, you must have knowledge of it. It can be locked away in HR, it can be locked away in a computer that only a single person can access, but you must have that knowledge there. And yeah, I think I've covered all of that. You need to audit regularly. I'll just go back to that one because I forgot it. You need to audit regularly to make sure that people are complying with the policies and procedures. The easiest way to do that is your clinical compliance audit. It's an annual audit and it picks up everything. You can do a whole heap of them. You can do them monthly, weekly, you can do them whenever you want to, but you must do it at least annually. You do not need to get an external person out to do and pay a fortune to get audited. It's a good idea every so often to make sure that you are on track. If you've got 2 or 3 agencies, sites within your network, you can get crossover auditing, so you can get someone from another site come and audit your particular site and then you can get together and talk about it. Okay, but you do need to do the auditing. Surveillance, we don't fit. We've actually got a semi-exemption because my argument is we don't fit the hospital-acquired infections criteria. We're not an inpatient facility, you're not inpatient facilities. We don't have patients for more than 48 hours. An infection is an infection that the patient gets after 48 hours in the organisation or 30 days post the procedure. We don't fit it. So I spoke to the department, I spoke to the NH and MRC, and we bashed it around a little bit and they said, no, you don't fit the criteria, but do a risk assessment. So we've done a risk assessment, which you can all do at your own organisation, and I looked at the 4 most invasive, what I consider the most invasive, which are your implants, your surgical extractions of WYSI, your general surgical extractions and endo. I pulled a whole lot of histories out over random time, random clinicians, etc. No one represented with an infection. There's no note on following presentations that they had an infection. No one was on antibiotics. So to me, we're at a low risk. So what I've decided to do, and you can decide yourselves what you want to do, is I am going to do what we call a point prevalence audit. I'm going to pick a day of the year I'm going to get everybody that's had those procedures histories, 30 days post the history, post the procedure, and review them. And I may phone them, although post-discharge surveillance is not that effective, but that's all I'm going to do, and I'm going to say, this is what we've done. And according to the department or the NHMRC, that's suitable. So you look at doing similar things. And yeah, that's the surveillance. And at the same time, at looking at all of those things, you can do a check on what antibiotics have been given and if they've been given properly, and that's discussed down further. And make sure everything's documented, that you actually have a documentation that you've done this audit and this is what you found. Criteria 2, it's just your strategies. It's to prevent infections. We cover bits of this. So hand hygiene. You all should be doing hand hygiene according to the Hand Hygiene Australia. That's our governing body for hand hygiene. You need to follow what they determine. There's not a lot of dental information on their site. We're in the process of doing a dental learning tool and having dental photos so that you can see. On the hand hygiene website, there's also the WHO, World Health Organisation, hand hygiene, I think it was called Hand Hygiene Guidelines for Community Health Services. There's 2 pages, pages 12 and 13 are on dental specific, and they fit really well with the 5 moments of hand hygiene. They've explained it. Like if a dentist is doing a procedure and he wants to go and look at the x-rays, he has to take his gloves off, clean his hands, look at the x-rays, switch it around, do whatever he wants to do, clean his hands, go back and do treatment. So it explains all of that to you. I know there's a couple of DAs that have now done the hand hygiene auditing course, which is fantastic. They've got a good understanding of doing hand hygiene audits. Nina here does most of ours, and you know we've got our own system in place, and I've had people from Queensland, Gympie, etc. phone us and say, you know, how are you doing and how are you working out? So, you know, we're sort of the leaders in hand hygiene in dentistry. We're the only dental hospital that actually submits or contributes to Hand Hygiene Australia's data, and we need to submit 3 times a year. The audits, again, you can do weekly, monthly, yearly. You can randomly say, I'm going to do an hour auditing and just quietly walk around. We do ours on the Hand Hygiene app that you can get from Hand Hygiene Australia. Do it on the iPad. All our audits are on the iPad, so, you know, it depends what mood people are in as to what they're going to comply with properly when we get up there. You know, I can see students when I walk around with an iPad who are walking around with their gloves off, who suddenly take them off and put them in the rubbish bin and go and squirt their hands. So, you know, there's still a bit of that Hawthorne effect out there. Observations for audits. If you're a tiny clinic of 1 or 2 chairs, observations aren't going to tell you anything. So you're better off looking at product use. So monitor your monthly product use, and then you'll know if there's a decline, then you know you've got to get in there and say, hey, you're not using as much hand hygiene, if you've not had enough patients, what's going on? So that's considered a good audit. And another one is just do a random patient questionnaire. And it's on the website, it's very simple. Did the doctor, dentist, clinician, whatever, did they do their hands? Did they clean their hands after they shake their hands? Did they clean their hands as they were going out? They observe very well. And don't worry about the general public. They are very, very well educated. They know very well. When we started putting it in the hallways here, the minute one would go up, we'd have a heap of patients coming and squirting their hands. So they know what's going on. So don't be worried about asking them to fill out the questionnaire. And it makes them be involved in what's going on. Your results have to go to infection control meeting, and they have to go up to CEO and board level. That's a requirement of accreditation, so make sure you get those results right up. I mean, even if it's just an email with results and it goes there so that they know what's going on. But you should be presenting them at your meetings. And if you notice poor performance, decrease in product use, decrease in your overall percentage, what we try and do here is get it down to find which cohort of people are pulling us down, and then we really concentrate on their education. And I mean, Nina's fantastic. She gets out with the light and the gel all the time and just says, here, try this, and then she goes on one-on-one education. The moment we're targeting a particular cohort of students because they're too worried about their exams and everything else, and they're shocking. But, you know, we'll get them up and they will get up, and with the help of everybody, they get up at it, and it's only one cohort, so that's pretty good. Immunisations, I spoke about this. Healthcare workers' immunisation guidelines on the Department of Health, revised in 2007. They are what you follow. There's nothing else that you follow. They are adapted from the NH and MRC immunisation guidelines booklet. They're specific for Victoria, and that's it. And it's very simple what you've got to do. It's the simplest way to follow it. You can look through the guidelines, the 10th edition, this one here. but it's quite complex and the healthcare workers spread all over the booklet. So the Department of Health Vaccination Guide for Healthcare Workers is a better one to look at. That's what you have to abide by. That's what you have to have set up in your clinic. And I'm going backwards now. Okay, OC Health and Safety. So we work very closely, OC Health and Safety and I, and sometimes I forget that I need to speak to Andrew about something, and sometimes Andrew does something that she's forgotten to speak to me about, but we still work relatively closely. Occupational allergies. Don't ask me about glove changing from latex to nitrile. It's been a nightmare here. So if you want help on transitioning, you can ask us because we now know what to do. But that was mainly to do with latex allergies within the healthcare service. But since we've been changing to nitrile gloves, we've got a lot of hypersensitivity because people aren't used to the nitrile. Once they get used to it, it's fine. And the dexterity is not as great. So we've had a few issues, but that's being sorted. Personal protective equipment to make sure that we've got good quality, plenty around, people are using it correctly, and that it's there. You must be involved in evaluation of new products. Any product that comes in your door that's going to be used in a clinical setting for a clinical purpose, you must know about. And if you're in a little clinic, then you definitely need to know about it. You definitely need to know that you can clean it properly. There's a lot of dental product out there, or dental instruments that have UK or US cleaning or manufacturer's guidelines that don't comply with Australian. The TGA doesn't actually look at that. They just want to make sure that they're sterilisable or they're washable, or you can use a high-level disinfectant with them. But lots of little components or cannulated equipment or nuts and bolts, we can't clean properly. And if they're being used in a critical space, you can't use them. So we've had quite a few discussions about things. We've had discussions with the TGA and with the clinicians involved who want to bring products in that we say, no, we can't clean them, we can't reprocess them, we can't, make sure their integrity and their cleanliness is there. And we're working with the TGA at the moment on trying to get the UK, which is definitely, normal sterilisation in Australia is 134 degrees at 3 minutes. UK is 134 degrees at 18 minutes. Now they're at 18 minutes because of their risk of their CJD from the cow, so mad cow disease. So they are automatically 18 minutes. All their sterilisers are set at 18 minutes. All our sterilisers are set at 3 minutes. So to get one set at 18 minutes, it means validating. Then we're going to drop it back down to 3 minutes, we've got to validate it. It's just impossible, we're not going to do it. So we've been told by TGA that we can, just presume that we can do the 3 minutes. But then we're going against what the manufacturer's guidelines are, so we're trying to sort that out at the moment, if that presumption can be there and if it's been tested otherwise. And there's something at the moment, they say, oh, just test it on a sheep's head or something to see if it's working. If you use a piece of equipment on an animal of any description, you can't use it back on humans, no matter the processing. So, there's just those couple of little things we need to look at. So make sure you're involved and that you understand the whole cleaning process. Some things you can do a risk assessment, say, it's not critical, doesn't go anywhere deep in the tissue and that, cleaning it to this level, washing it or putting it in a high-level disinfectant is adequate, right? But you have to take that on board. Make sure the safe working environment and so that any infection control practices or policies that are written comply with OC Health and Safety. 3.9, invasive devices. You have none out in the agencies. There is nothing, okay? Don't try and make something up by saying, a perio probe because it might go into the tissue as an invasive device. You do not have any, you don't have to do it, you just have to acknowledge that you don't have them, okay? An invasive device is a central line catheter, okay? One that goes here or in here down into the heart chamber. It sits in the heart chamber. An arterial line goes up in your artery, so it's deep and it's in your artery and it goes direct flow to your heart. Your PICC lines are your long-term IV lines that can go in here or go in here, but they actually almost sit into the cardiac chamber as well, and your indwelling catheters and intravenous lines. The only thing that we can ever even consider that might be slightly invasive here is our IV cannulas. We have short-term, maybe a couple of hours. They have them in day surgery unit to put the person asleep and to give them some IV fluids while they're asleep. They're taken out as soon as they're not needed. So our risk of infection is non-existent, but it's still tiny, it could still be there. So when I get onto aseptic non-touch technique, we'll go into what we need to do. You don't need to do it out in the agencies. If you're putting IV cannulas in, well, you shouldn't be unless you've got somebody that's trained, and that'd be an RN or a doctor. or an ambulance officer that's working out there. So that's it. So don't panic about that because you don't need to know. Aseptic technique. It's called aseptic non-touch technique in the UK. We started calling it aseptic non-touch technique here. We're not allowed to because it's their trademark internationally. So we just call it asepsis or aseptic technique. It's nothing new. It's just it's been done in a whole lot of various different ways. And you know, even when I came here, the endo guy saying, "Oh no, this is a sterile procedure." I'm going, but you have no sterile gloves on. You have no sterile gown on. You have no sterile area that you're working in. The airflows are going every which way. This is not sterile. So we have talked that out and we have reviewed our practices. So what you need to do is understand what asepsis is. The national guidelines in their part section on asepsis, which sometimes I have trouble finding, but it's definitely there, explains what asepsis is. Right? It explains what environment the different level of asepsis need to be done in. Okay, it's all there, the explanations are there. As soon as the policy gets approved here, it'll be available for you to look at anyway. And you can, you know, do what you want with it. I'm happy once it's been approved at this level. So you need to do a baseline. You need to go around and say, well, this procedure's done doing this procedure's done doing that, this procedure's done they've got sterile equipment that needs to maintain sterility, so they need a key point. So you need to go and look at every procedure that you do. We've done that. And the only truly sterile procedures that we consider sterile procedures here are implants, and anything that's done in our day surgery we do as a sterile procedure, even though if it was done in the chair it wouldn't be, but because of the environment it is. But again, you've got to look at the environment that it's done in, and you're probably better off than we are because we're very open surgeries or spaces. You've got closed areas, so you can actually have a higher level of sterility than what we can have here. Our closed surgeries can, but implants are done in an open space, which is not ideal. They should be done in their own enclosed room, so you've got a better control over them. You have to make sure that they understand why they're using sterile and non-sterile gloves. They use non-sterile gloves in the general dentistry to protect their own hands. They're not doing it for the patient. You could do dentistry with no gloves on, but your risk of getting blood and body fluids and cuts and scratches over your hands is too great. So hence we use gloves as a barrier. And sterile gloves are used for sterile procedures, and you need to scrub as a sterile scrub. You need to have a sterile gown on, you need to have sterile gloves on. It's a sterile procedure. Mask, goggles, the rest of it, not necessarily a hat. So there's a difference in why you use them. And just because you're using sterile gloves doesn't make it a sterile procedure. Okay, it's an overall procedure that's sterile. Aseptic field, there's general and there's critical. Most of our stuff is general. If you're using syringes over and over again, or you're squirting into the canal over and over again, you have an area, and our endo guys are great at it. They have an area that all their files sit in, all their needles for irrigation, everything sit in. They definitely designate a spot. The rest of their instruments and their used stuff is away from it. And that's what they look at. Have a key area within your tray or space, workspace, that is for sterile instruments, or as clean as possible sterile instruments as you can. And it'll be, you know, your needles that you're putting local in over and over again, like they dangerously bend those needles and put it in the canals, etc. Okay? So it's for all those things, and it's very easy to define. If you're doing procedures, get bigger bracket tables if you need to. If you find you're really cluttered and you can't get that area away, have bigger bracket tables for those procedures. Standard asepsis. This is defining the field. This is designing what you're doing within that field. And it's a little bit confusing, but it reads well when you read it. So standard asepsis are most of our procedures. Okay, they may have a critical field, they may not have a critical field, but they're general standard asepsis. Implants and our surgical procedures, whether they be in our oral surgery or our day surgery, we consider sterile. But the closest to a truly sterile field that we have, or sterile area that we have, is day surgery, where the airflows are controlled at 20 changes per minute. 20 changes per minute. That the flow of people is controlled, the doors are shut, and your equipment remains as clean and as tidy as possible. And you're quite acutely aware that this is a surgical procedure, I need to behave myself. Okay, but in other areas, implants, If you're doing them in an open space and everyone's walking backwards and forwards and there's big, conversations and that going on, forget it, it's not sterile. All right, so you need to think seriously about those things. So establish your baseline, develop your policy and procedure. You must educate everybody so they don't get confused when the accreditors come and they say, well, what sort of a procedure is this? They understand that this procedure is a sterile, this is a non-sterile, this is a basic, whatever. They need to understand that and evaluate them. You have to have an evaluation form, you have to audit the procedures. And if someone's not doing it correctly or doesn't understand it, you have to go through it. And one-on-one in our situation is probably the best way to tackle that. What's going to happen is the policy is going to be just a heading under infection control here on our website, and it will go to a clinical guideline. The clinical guideline will have the whole background and what you need to do in procedures, and it'll have some questions, and that's going to be the learning tool. And we can know who's been there and who hasn't been on and whatever. So that will be available to the agencies as well as to the hospital. So it's a good way to go. So I'll keep you informed of when that goes in. Now, as far as for accreditation for you guys, you're developing it. So everything that I've said, you can write down and say, use the presentation, I don't care. This is what we're working towards. I have to have it in place. I have no chance to develop it. Oh God, I better get cracking. Managing patients with infections or colonizations. If someone turns up and they're sick, if they need emergency treatment, treat them. If they don't, send them home, change their appointment. If they don't tell you you're sick, well, you can't do anything about it. Okay, I got a DA and a dentist that got chickenpox from a patient who hadn't yet had symptoms of chickenpox but developed symptoms of chickenpox. We then ended up with 4 DAs with chickenpox, just simply because we didn't know. And you can't do anything about it, but I had to stop and make sure that those guys were at home, looked after, and no one else got sick. So you need to be aware of that. This is just following. This is part of your compliance audit. This is making sure that your standard and transmission precautions are being practiced and that you've got the equipment that's ready for people. So you need to, we do the clinical compliance audits, which you've all got access to, that we're just about to tweak a little bit because the sterilisation component's not quite right for the agency, so we're tweaking that at the moment. You do environmental audits. By environmental audits, I mean your clinical space audits. So you watch that the DA does actually clean the chair properly. Don't go in there and Google eye them. Just, as you're walking past, make sure that their motion of cleaning is correct, that they're actually cleaning every component. You can get some tools, you can get textures that you can put in key spaces and then shine your black light on and it tells you whether they've cleaned it or they've not cleaned it. And we're doing that at the moment. We're running around with our little textures just to warn you all, putting it on sites that we don't think get cleaned all that well, and then we'll address that person one-on-one. But we've got to sneak around because they don't know we've got the black light. The hand hygiene audits, do whatever you want to do, whether it be product, whether it be actual direct observation audits. Waste audits, every so often you've got to make sure that your rubbish bins have got the right product in them, that they're not putting bloody products over bloody products in general bins, that they're not putting gloves that have been used for the patient in the clinical waste. You've got to look at all of that. There's no sharps in bins that shouldn't be, etc. That's being used properly. And your linen use, that their gowns are being used properly, that they are taking them off the right way, they are storing them for later if they're going to. I still can't cope with not having a different gown for different patients, so I still, after 4 years, still struggle with this. But I have to keep telling myself it's to protect your clothing, it's not to protect the patient, so it's okay. So we're not actually bear hugging the patients or whatever, but I still have trouble with the gowns. And all of these audits, whatever you want to do, make up your own audit, do a random audit, just do, water use audit, just whatever you want to do, make sure it travels up to the hierarchy. Make sure the board know what you're doing. And who knows, it might become a whole health centre practice rather than just a dental one. Another one that's not totally relevant to us, it goes back to the other one, if the patient's sick, send them home. Or send them to the doctor rather than doing them at the clinic, unless you need urgent work. Okay, so if someone's got a rash or they just don't look well, don't treat them. It's not worth putting everybody at risk. Their dental treatment's not urgent. We like to get it done, but it's not urgent. Just rebook them in a little while. It goes for your staff as well. If they've got an influenza-like illness or they've got gastro, don't come to work because the whole department will be shut down, especially with gastro and the way it spreads and what they're telling us is coming. Don't come to work. And 48 hours after your last episode of diarrhoea or vomiting, you need to stay at home. Because you shed the virus. You can actually shed the virus up for 42 to 72 days. So, you know, really you need to stay home. Treat them if it's an emergency. Make sure every patient that you see, you have an accurate, up-to-date history taken. So every visit you need to go through that history and make sure that it's okay. Not the DAs don't, but the clinicians do. And you really aren't going to be aware of anybody sitting in your waiting room that has an infectious disease. You're not going to know. Because half the time they don't know. Okay? And if you're going to refer anybody, not from your clinic to us, but you know, you're referring, this ties in more with the patients, an acute patient in an acute hospital, they're going to a nursing home, they've got this disease still. You need to let them know that. So, you know, if you are sending an aged lady to somebody home to a nursing home and you think they've got something, or they've had a bit of gastro or diarrhea or something while you've had them, or they're coughing or spluttering or whatever, just let them know that that's going on. Antimicrobial stewardship. Policies being developed. What you need to do for dentistry is basically look at what your procedures are, look at what antibiotics you need to give, look at the therapeutic guidelines and adapt it. Now I've done one and it's so complicated that I've got someone helping me with it so we can simplify it. So we've got disease listed and we've got some tables of which different combinations of drugs are, and we'll say see table such and such, because it's pages and pages and pages of this treatment, this antibiotic, this treatment, this antibiotic, but there's a lot of repetition, so we're trying to get it down to a tiny little page. You need to write a policy on antimicrobial stewardship. Write when you give antibiotics, for what reason. There's some procedures that you don't need antibiotics. There's very little prophylactic antibiotics that need to be given. It's all in the therapeutic guidelines. You don't give antibiotics because, or in case, or maybe, or I think I feel better if I do. The patient needs to have the antibiotics. The procedure needs to dictate that they need the antibiotics, and their own condition needs to dictate. So you write your guidelines, and hopefully I'll have it up and running soon. Educate all your clinical staff on the new process so that everybody knows what's expected of them, because you're going to audit them. All right? So you need to make sure they're all aware, and monitor the usage. This is usually done by a pharmacy department. We don't have a pharmacy department that's our own. So what we're going to do is grab random histories out again once a month. We'll do 15 to 20 of them, and we'll see if they were given antibiotics and what the reason behind them having antibiotics was for, and then go back to the clinicians and say, you've given every patient you've seen today antibiotics. This one didn't need it, this one didn't need it, you know, this one probably did, and prophylaxis as well. And that may change when we get better at working out what we're doing. Feedback the results to the clinician and your infection control committee again, and feed it up to the top. Okay? And really I hope that that's up and running by the end of the month, because that's my time frame. Again, don't panic about it. It's quite an easy process. It's just I just need to get it tighter. It's just too loose and wishy-washy at the moment. 5, cleaning, disinfecting and sterilisation. Make sure you've got all your policies, comply with whatever standard you're using, they're actually doing it correctly, and it actually gets audited regularly. Okay? And you have to have all the documentation, or your sterilisation documentation, or your releasing, you have to have a recall policy, etc. Okay? To process for instruments that have taken out, that are not used for the patient, to make sure your instruments are stored for the correct time, in the correct place. Those who've had me out there know what I'm talking about. You know, your 28 days is here, it's an absolute. Out in the clinics, 28 days, 3 months, 6 months, 12 months before you have to reprocess. It depends where the instruments are, how often they're touched, and how you look after them.
Wendy, we're running over now.
Oh, okay, cleaning, make sure it cleans. Make sure the cleaners that are employed comply with those guidelines, okay? They must comply with them. They can argue, the contractor can argue, they must comply with that, okay? And make sure they're audited regularly. That's just sterilisation, just what I said before. And involved your carers, involve your patients, involve everybody, and communicate with them. We're doing a series of, I used to plagiarise and borrow everybody else's, and mainly from the Grampians region, but they're not printing them anymore, so we have to do our own. So comms at the moment are getting, we've got hand hygiene, we're about to do influenza-like illness, if you've got a gastro-type illness and that sort of stuff. So the patients have got them there so they know and have access to them, and they're all in our correctly branded. So I'll let you know when they're available too, and you can put them in the clinics. So that's what we're doing, cough etiquette, especially in this season, make sure tissues and hand hygiene are available for the patients, etc. Done.
Well done.